Bismillah ar rahim. Alright, everyone, let's kick off with a really interesting case from AJKD. This is a 16-year-old patient who came in with full blown hypertension emergency, the kind of scenario that forces us to slow down and think carefully and go back to first principles. I'm Dr. Mahmoud Sheikh, a nephrology consultant, work in the academy instructor, and I'm interested in online nephrology learning and education. I'm going to walk you through this case, but more importantly, we will use it as a doorway into something bigger. How to approach the diagnostic algorithm with real clinical reasoning, tips, tricks, and pattern recognition, skills that most textbooks simply don't spell out. This case gives us a perfect opportunity to highlight the subtle clues, red flags, and sequencing of investigations that can completely change the trajectory of care. By the end, you will see how a case like this is not just an emergency, it's a teaching moment that sharpens how we think about secondary hypertension in the young. Now, moving into the clinical presentation. So, here we have a 16-year-old boy who shows up with 3 weeks history of worsening headaches, nausea, vomiting, and blurry vision. Over the last 3 days, things escalated. He developed chest pain, shortness of breath. That's already telling you this is not just hypertension, this is physiology under real pressure. On examination, his blood pressure was 204 over 145, which is severe for anyone, but especially for a teenager. Cardiovascular examination didn't give much away, but the EKG showed inferior ischemia and LVH, and ophthalmology team found cotton wool spots, a classic signs of end organ injury. There is also something subtle here, family history of sibling with hydronephrosis, which becomes relevant once we open the diagnostic algorithm. The labs and data add another layer, metabolic alkalosis with hypochloremia, hyponatremia, hypokalemia, and elevated creatinine, elevated troponin. This is not a typical lab profile of simple essential hypertension. These abnormalities are clues, little breadcrumbs that point towards secondary causes. He was started on nicardipine, stabilized to 140s, 150s, and then transitioned to multi-drug therapy with amlodipine, doxazosine, and spironolactone and hydroxyzine as needed. What makes this side important is not just the data, it's what the data implies. This case opens the door to a larger discussion about the diagnostic algorithm and how to pick up subtle physiological signals that textbooks mention but don't fully teach. These patterns, electrolytes, retinal findings, EKG clues, family history are where the real diagnostic tips and tricks live. Let's take a closer look at the laboratory values. The labs here are not random numbers, they are telling a very specific physiology story. Start with electrolytes. Sodium is 131, potassium is 2.8, chloride is 89. That's a triad of hyponatremia, hypokalemia, and hypochloremia should immediately make you think about secondary cause of hypertension rather than a simple volume issue. And when you pair low chloride with CO2 33, you are looking straight at metabolic alkalosis, which narrows the differential even more. Creatinine is 1.26, which is mildly elevated for a healthy teenager. So kidneys are already under stress, as we mentioned. Then you see a troponin of 307. This is not a primary cardiac case, but it reflects end organ injury from extreme blood pressure and stress. Now, here is where the diagnostic algorithm becomes powerful. Most textbooks list these abnormalities, but they don't teach you how to see them as a coherent pattern. When you connect metabolic alkalosis, hypokalemia, low chloride, elevated blood pressure, and the patient's age, you are pushed toward a very specific cluster of diagnoses, particularly those involving ROS activation. This slide really sets up our deep dive into algorithm, how to interpret labs in a way that guides you toward hidden secondary causes, cooking in dark. Now, this is where the AJKD case really becomes valuable. because it naturally pushes us into key questions that shape the entire diagnostic pathway. The first thing we have to ask is what additional tests are needed in a teenager with hypertension, hypokalemia, and metabolic alkalosis. You can't afford to shot in the dark. The choice of test and sequence matters. This is where the diagnostic algorithm gets interesting because there are specific labs and imaging studies that can dramatically narrow the differential diagnosis if you interpret them in right order. Next, we need to build the differential diagnosis. And again, this is one of those areas where the textbooks give you a list, but they don't teach you the clinical logic behind that list. When you put hypokalemia, metabolic alkalosis, and severe hypertension together, the pattern points you toward a very focused set of possibilities. We will break that down step by step with the practical tips that make the algorithm crisp and usable at the bedside. Finally, we will look at radiological studies, what they show, but just as important, what their limitations are. Imaging can guide you, but it can also mislead you if you don't understand the physiological context. EGKD does a great job highlighting this once, and we'll walk through exactly how to interpret the finding in a case like this. So, these three questions form the framework for the rest of discussion, and they open the door to all the diagnostic periods that are rarely written clearly in textbooks, as we mentioned. Now, the differential diagnosis for hypertension with hypokalemia and metabolic alkalosis is all about understanding the renin-aldosterone axis and using it in the right way. The entire algorithm really starts with one thing: measure renin-aldosterone after correcting the potassium level. That step is essential and is one of the clinical perils that textbooks mention, but they really emphasize how dramatically it changed your interpretation. So let's break it down in a practical, real world way. If you get high renin and high aldosterone, your mind should immediately go towards conditions that ram up the renin pathway, renovascular disease, renin secreting tumors, or malignant hypertension. This is classic secondary hyperaldosteronism. If you find low renin and high aldosterone, that's primary hyperaldosteronism, most commonly an adrenal adenoma or bilateral hyperplasia. That's the Cohn's pathway. And if you both renin and aldosterone are low, that's where you look for the more unusual but high yield causes like Liddle syndrome, apparent mineralocorticoid excess, congenital adrenal enzyme defects, or even licorice toxicity. These are the diagnoses that you only pick when you are really know the physiology. The AGKD also reminds us that renovascular hypertension can present with hypokalemia and metabolic alkalosis because renin levels are elevated. Think of conditions like fibromuscular dysplasia, vasculitis, such as Takotsu's arthritis, neurofibromatosis, related vascular changes, or even congenital anomalies. These aren't associated with metabolic alkalosis, are consistently, but they should always stay on your radar in a teenager with severe hypertension like our patient. So this entire slide is really the diagnostic roadmap, an algorithm that ties together renin, aldosterone, electrolytes, and clinical presentation in a way that textbooks don't spell out clearly. This is where pattern recognition becomes more powerful than memorizing lists. Let's talk about the additional tests. First, the core labs were expanded to include renin, aldosterone, plasma metanephrines, serologies, and targeted imaging. That combination is not random, it's a very deliberate move to separate endocrine causes, renovascular causes, and systemic inflammatory conditions. This is a part of textbooks often oversimplify, but in real clinical practice, the order and timing of these tests matter. The initial renal ultrasound with Doppler showed an echogenic heterogeneous kidney, but without clear evidence of renal stenosis. This is a classic example of how ultrasound gives you a hint but not the full picture. Cross sectional imaging with CTA and MRA went a bit further. They picked up a questionable left adrenal nodule, but again, no convincing renal artery stenosis found. This is where experiencing clinicians pause because imaging can be misleading in young patients with renal vascular disease. Sensitivity and specificity vary widely uh, depending on the technique, somewhere between 62% to 97% in sensitivity and from 84% to 93% specificity, especially for FMD. And that brings us to the key reminder. Angiography remains the gold standard for diagnosis of fibromuscular dysplasia. No matter how advanced CTA or MRE become, they can still miss subtle lesions, especially in the mid to distal renal artery, which is exactly where FMD tends to hide. So, this slide really highlights the practical diagnostic sequence. Start broad, use imaging wisely, understand the limitations, and know when to escalate to angiography. On this slide, we are looking at the additional lab values. And before we dive in, yes, I know there is literally an elephant in the room on the slide. I put there on purpose because these labs do raise an elephant in the room question that we need to confront directly. Starting from top, we have a renin activity of 78, which is massively elevated compared to the usual upper limit of about 5 to 6. Aldosterone is 88, also clearly above the expected range. When you pair that combination, very high renin and high aldosterone, it immediately pushes us towards secondary hyperaldosteronism as the key issue. Then the plasma metanephrines come at 210, slightly above the cutoff value, not dramatically elevated, but enough to make you pause for a second. ESR and CRP are only mildly elevated, ANCA is negative, and complement C3 and C4 are sitting comfortably with normal limits. So the elephant in the room here is this. What's driving this exaggerated renin-aldosterone axis? Is it renal artery stenosis or a malignant hypertension? Or is it something more subtle like renin secreting lesion? The rest of labs don't point toward an inflammatory or autoimmune process, which helps to narrow the focus. That's why this table is so important, not for what it shows, but for what it quietly rules out. And that lets us keep our attention on the real elephant walking across our diagnostic pathway. Whenever you are faced with hypertension plus hypokalemia plus metabolic alkalosis, everything hinges on interpreting renin aldosterone correctly. After repleting the potassium, of course, this flow chart breaks into three pathways, and once you understand them, the entire differential becomes intuitive rather than overwhelming. On the left side, if both renin and aldosterone are high, you're dealing with secondary hyperaldosteronism that pushes you towards things like renovascular hypertension, renin-secreting tumors, or even malignant hypertension driving renin up. This is where imaging, Doppler, CTA, MRA, eventually angiography become more important. In the middle, we have low renin and high aldosterone, that classic primary hyperaldosteronism. Think of an aldosterone producing adenoma or bilateral adrenal hyperplasia. This is the Cohen's pathway, as we mentioned. It's one of the most important patterns to recognize in young hypertensive patients or even in the exam purpose. And then on right side is a subtle but high yield group, low renin and low aldosterone. This is the pseudo hyperaldosteronism category. Liddle, apparent mineralocorticoid excess, congenital adrenal gland defects, and even licorice toxicity. These conditions behave like aldosterone excess, but aldosterone itself is quiet. That's a kind of nuance that doesn't always come through clearly in textbooks, but the physiology makes perfect sense when you see it in organized way. So this algorithm is not just a diagram; it's a roadmap that ties the entire case together. Once you match the patient's labs to one of these three renin aldosterone patterns, the rest of diagnostic workup becomes logic and targeted rather than a broad and confusing issue. Now let's take a look at the radiological findings. The renal angiogram is the key study here, and what it shows is far from typical renal artery stenosis. Instead, we see multiple saccular aneurysms coming of the segmental and interlobar branches. Those are the red arrows in the figure. They involve second and third order arteries and are spread across both the upper and lower poles of the kidneys. Along with that, there is clear tortuosity and narrowing of several peripheral renal arteries, the yellow arrows. And interestingly, there is even a small splenic artery aneurysm shown. All of these together points toward an arteriopathy rather than simple focal stenosis. Now, we usually think of fibromyalgia dysplasia as a classic string of beads pattern, but this case is a great reminder that FMD can present with alternative patterns, especially in early or atypical cases. It may appear as focal or smooth tubular stenosis, isolated microaneurysm, or a mixed picture like what we see here. The limitation, and this is an important teaching pearl, is that relying only on CT or MRI often misses these subtle branch level abnormalities. Angiography remains the gold standard because it can reveal exactly this kind of fine vessel disease. When you are evaluating a young patient with severe hypertension and abnormal electrolytes, this level of detail matters. Finally, the histology on the right, panel C, shows an arteriole that occluded by a thrombus consistent with TMA. So now we have a radiological evidence of arteriopathy and microscopic evidence of vascular injury, which helps explain the patient's presentation far more clearly than any single study alone. Again, this is where HKT case really illustrated differently from our textbook. So after putting all the pieces together, the electrolytes, the renin-aldosterone pattern, the angiographic findings, and the microscopic evidence of vascular injury, the EGKD case leads us to the final diagnosis, renal vascular hypertension due to multifocal fibromuscular dysplasia. What's remarkable here is how this diagnosis explains the entire clinical picture. The severe hypertension, the metabolic alkalosis, the hypokalemia, the elevated renin, and even the microaneurysm on angiography. It is kind of case where the physiology guides you more than any single test. The patient was started on low dose ACE inhibitors, and the response was dramatic. Blood pressure dropped quickly, and most of the other antihypertensives could be discontinued. It's a great reminder that once you identify the true driver of the hypertension, the treatment becomes much more targeted and much more effective. So, in this slide, really wraps up the story: complex presentation, subtle clues, limitations of routine imaging, and finally, a very specific diagnosis that ties every abnormality together. Going to this part of the lecture, which is made by my experience, my humble experience, which is designed as a clinical reasoning toolkit, not just a review of definitions. Because when you see this tried in real practice, the textbooks give you a list of possibilities, but they rarely walk you through the actual logic that helps you separate the common from the dangerous or the obvious from the subtle. Um, what I want to share with you over the next few minutes is exactly that: the practical diagnostic errors, the algorithmic shortcuts, the physiological red flags, the things that textbooks don't tell you clearly. By the end, you will see how this triad is less of a mystery and more of a map pointing you toward the right diagnosis if you know how to read it. When you boil this entire triad down, hypertension, hypokalemia, and metabolic alkalosis, the core diagnostic question is surprisingly simple: who's the bully? Who's driving the physiology? And once you answer that, everything else falls into place. There are really three possibilities bullies in this story. Number one, aldosterone itself. This is where the problem and actual excess of aldosterone, classic primary aldosteronism. The gland is overproducing the hormone and the kidneys are simply responding to it. Number two, and aldosterone mimic. Something behaves like aldosterone even though aldosterone isn't elevated and very quiet. This includes Liddle syndrome, liquid toxicity, and even conditions like Cushing's that activates the mineralocorticoid receptor indirectly. The physiology looks identical, but the hormone levels tell a very different story. And number three, renin-driven disease. This is where renin is really bully um, driving aldosterone up. Secondarily, think of renal vascular hypertension, renin secreting tumors, or even malignant hypertension, as we mentioned before, pushing the ROS pathway into overdrive. The moment you identify which of these three categories your patients falls into, the differential shrinks dramatically. This is why measuring renin-aldosterone after correcting potassium is so powerful. It doesn't just give you numbers, it tells you who's in charge of the entire pathophysiology. This simple framework is one of those practical reasoning tools that we should follow. Before we jump deep into renin-aldosterone patterns, there are two quick exclusions that every clinician should do upfront. These are the first checkpoints, the things you rule out in first 10 seconds because they instantly reshape your differential. First, gentleman and Barter rule. These salt wasting tubulopathies almost never cause hypertension. So if your patient presents with hypokalemia, metabolic alkalosis, and they are hypertensive, you can confidentially take gentleman and Barter off the table. It's one of the biggest clearly shortcuts in the diagnostic algorithm. Second, the gender clue. If the patient is young woman, always test for pregnancy before anything else. Pregnancy dramatically alters the ROS system and it can completely change the interpretation of renin, aldosterone, and electrolytes. Missing pregnancy early creates a huge diagnostic confusion and is one of the easiest mistakes to avoid. So these two steps, excluding the salt wasting syndromes and checking pregnancy in the right patient, clean up your differential immediately and they prevent you from going down the wrong diagnostic pathway from start. These are simple rules, but they are exactly the kind of practical pearls that textbooks really lay out clearly. Here is a really useful bedside maneuver that many clinicians overlook, the so-called spironolactone test. It's not a formal guideline recommendation, but can be incredibly revealing when you are trying to sort out this triad of hypertension, hypokalemia, and metabolic alkalosis. The idea is simple: give a small dose of spironolactone and watch out what happens over the next hours to days. If the blood pressure improves, the potassium rises, and alkalosis start to correct, then the physiology is telling you something very clear. This is aldosterone driven. Think primary aldosteronism or renin mediated process like renal vascular hypertension. Spironolactone blocks the mineralocorticoid receptor, so improvement basically means aldosterone was the bully all along. But if there is no effect at all, that's just an informative. It means the problem is not in aldosterone. Now your differential shift toward things like Liddle, licorice, apparent mineralocorticoid excess, conditions where the mineralocorticoid receptor is activated without aldosterone being involved. And again, the important disclaimer, this is a crude clinical maneuver, not an evidence based diagnostic test, but in the right patient can help you separate the big diagnostic categories very quickly. It's one of those practical real life tools that textbooks really explain clearly, but clinicians remember it because it really works. Here is one of the easiest giveaways in the entire differential, something very clinician should lock into memory. Liddle syndrome doesn't respond to spironolactone, and that makes perfect sense when you understand the physiology. The problem in Liddle syndrome isn't aldosterone at all. The mineralocorticoid receptor is not overstimulated by the hormone. It's the intact channel itself that overacted because of a genetic gain of function mutation. So when you block the receptor with spironolactone, nothing happens. No improvement in blood pressure, no improvement in potassium, no correction of the alkalosis, and that lack of response is actually a powerful diagnostic clue. But the moment you give amyloride or trimetrine, which directly block ENaC, these patients improve dramatically. It's almost like flipping a switch. This is one of those classic clinical pearls that textbooks mention briefly but don't really emphasize the reason behind. In real practice, is often the key clue that help you separate Liddle syndrome from aldosterone-driven disease within a minute from the start. Now, before we move any further, we need to talk about two of the biggest lab traps that trip people up all the time when evaluating this triad. The first trap, the back PR ratio. This ratio is extremely helpful, but only under the right conditions. If the potassium is low, the ratio becomes basically useless. Hypokalemic actually suppresses aldosterone secretion, and that can give you a false negative result. So if you try to interpret the back PRA ratio before correcting the potassium, you're reading distorted picture. The rule is simple: always correct potassium first. Always. Second trap, the normal potassium illusion. We love to associate primary aldosteronism with low potassium, but the reality is different. Up to 40% of patients with primary aldosteronism have normal or near normal potassium levels, so a normal potassium does not get you off the hook. If the patient has persistent or persistent metabolic alkalosis, you must still screen for primary aldosteronism even if the potassium looks perfectly fine. These two traps are responsible for a huge numbers of missed or delayed diagnosis. Once you understand them, your interpretation of renin-aldosterone and the clinical picture becomes much more important and accurate and far more meaningful in real practice. Now, let's look at part two of the lab traps because this is where clinicians often misread renin-aldosterone and end up going down the wrong diagnostic path. First, the concordance rule. Under normal physiology, renin and aldosterone move together, they rise together, they fall together. So, whenever you see a mismatch, what we call discordance, it's almost always a pathological. And once you memorize the three patterns, the differential becomes incredibly straightforward, as we mentioned before. This rule alone organized 90% of the differential. Second, the renovascular clue in renal artery stenosis, renin doesn't just increase in skyrocket, uh, not increase in simple way, but it skyrockets. But aldosterone often does not raise proportionally. So when you see PRA out of proportion to aldosterone, that's your red flag for a renovascular cause. This is one of those subtle but powerful diagnostic barriers that textbooks rarely teach clearly. Once you understand these patterns, interpreting renal aldosterone becomes less about memorizing and more about recognition, the physiology talking to you. Now let's talk about the great mimics, the situations where both renin and aldosterone are low, but the physiology looks exactly like mineralocorticoid excess. These are cases that confuse people the most because on paper it looks like aldosterone is the problem, but aldosterone is actually quiet. Something else is acting like it. First mimic is Cushing syndrome. When cortisol levels get very high, the hormone overwhelms the enzyme 11 beta HSD2, which normally protects the mineralocorticoid receptor. Once that enzyme is saturated, cortisol starts behaving like aldosterone, driving hypertension, hypokalemia, and metabolic alkalosis. So anytime you see this triad with low renin and low aldosterone, always check for cushingoid clues like weight gain, stria, bruising, and proximal weakness. And second mimic is licorice. This one sounds harmless: tea, candies, cough syrups, but licorice contains a glyceric acid, which inhibits the same enzymes 11 beta HSD2. The result is identical to Cushing. Cortisol floods the mineralocorticoid receptor and acts like aldosterone. So this is one of those situations where a simple questions: do you take licorice, herbal teas, or traditional remedies can solve the entire puzzle. These are classic examples of how physiology can trick you. Low renin, low aldosterone doesn't always mean Liddle or AME. Sometimes the problem is cortisol or something your patient is eating or drinking. Let's move to the physiological principle behind the physical exam because this is where a lot of real diagnostic powers lies. If you know what to look for, the exam often point you to the answer before you even get the labs back. First, volume status. In states of mineralocorticoid excess, patients are typically volume expanded. That's because aldosterone or something like it is driving sodium retention. In contrast, vomiting or diuretic abuse lead to volume depleted state. This simple distinction can separate two completely different diagnostic pathways within seconds. Second, the no edema clue. This is one of my favorite pairs. Even though these patients are volume expanded, they usually don't have edema. Why? Because of physiological process called aldosterone escape, driven by pressure natriuresis. So when you see a triad hypertension, hypokalemia, metabolic alkalosis, but the patient has no edema, that's a subtle but important clue that physiology could be behind aldosterone rather than heart, liver, and kidney failure. And third one, the renal pyruvate. This might be the most underused diagnostic sign in all of nephrology. If you hear a flank or gastric pyruvate, especially in young patients with this triad, that's almost diagnostic of renovascular hypertension, including fibromuscular dysplasia. As our patient, a 2-second listen with stethoscope can give you a clue that no blood test will. These clinical clues may seem small, but together you act like signposts that guide you toward the right branch of the diagnostic algorithm long before the imaging comes back. Now let's talk about two major clues, imaging and patient profile, because this can completely shift how you interpret the triad. First, the imaging trap. This is a classic mistake. Normal CT scan doesn't rule out primary aldosteronism. CT is great for many things but can easily miss microadenomas, which are often the real culprit in primary aldosteronism. So you should never let a clean CT override the physiology. The rule is simple: always trust the physiology over the picture. If the lab screams primary aldosteronism but the CT is normal, keep going. And remember, adrenal vein sampling (AVS) is the gold standard for lateralizing aldosterone production, not CT and not MRI. Second trap, the age clue. Age helps you to sharpen the differential quickly. If the patient is young, especially under 30, your brain should shift toward genetic causes like Liddle or GRA. If the patient is child, genetics move right to the top of list. Liddle, AME, congenital, adrenal hyperplasia, four more likely than classic primary aldosteronism. So between imaging traps and age clues, you start to see how powerful it is to combine physiology with the patient's profile. These simple filters help you to avoid misdiagnosis and keep you anchored to the right path in the diagnostic algorithm. Before we wrap up the diagnostic algorithm, it's worth highlighting a few key physiological principles that explain why this triad behaves the way it does. These principles often get buried in textbooks, but once you understand them, the entire pattern suddenly becomes logical. First one, potassium is the signal. Hypokalemia normally suppresses aldosterone. So if you see a patient with low potassium but still high aldosterone, that tells you that aldosterone excess is truly autonomous, strong enough to override the body's natural suppression. That's a huge clue pointing toward primary aldosteronism. Second, the real cause of metabolic alkalosis is not just the loss of potassium. Aldosterone directly stimulates hydrogen secretion through the HATPs in the intracranial cells, so the alkalosis is actually a direct hormonal effect. This is why alkalosis often improves so quickly when you block the mineralocorticoid receptor. And third, the Bushra test. This is a classic physiological trick. In primary aldosteronism, aldosterone is autonomous. Doesn't care if the patient is lying down or standing up. But in renal vascular hypertension, aldosterone is driven by renin. So when the patient stands, renin surges and aldosterone rises significantly. A big Bushra-related jump strongly suggests a renin-driven process. These small physiological details may seem subtle, but they are incredibly useful. They help you interpret borderline labs, recognize false negatives, and understand the underlying mechanism, not just the numbers on the page. All right, everyone, that brings us to the end of session. I hope this breakdown of hypertension, hypokalemia, and metabolic alkalosis gave you a clearer, more practical way to approach this triad, especially those periods that textbooks don't always spell out. If you have any questions, feel free to jump in or drop a comment later, and we'll be happy to keep the discussion going. Um, and if you enjoy this kind of clinical reasoning content, I share more of it on YouTube channel, case-based reasoning, algorithm, and nephrology deep dives. Thank you all for listening and see you soon. Goodbye.